Welcome. In today's session, we are going to look at the anterior compartment of the leg, also known as the extensor compartment of the leg. And by the end of this session, you should know what is fascia cruris and some of its modifications. Also, you should know the muscles of the anterior compartment of the leg, the neurovascular supply of the anterior compartment of the leg, and some clinical correlations. Here should be clinical correlations. Welcome all. My name is Maurice Monyeri and I'm the URI doctor. So, the anterior compartment, the fascia cruris. Now, the deep fascia of the leg is very strong and encloses the leg like a tight sleeve. Now, the fascia, remember the deep fascia of the thigh is known as the fascia lata, but the deep fascia of the leg is now the fascia cruris. The leg refers to the part of the lower limb between your knee and ankle. Okay, so it does not cover the subcutaneous bony surfaces and it is attached to their borders. So it is attached to the borders of the anterior tibial border. It is attached there. So it usually blends with the in other words, it is fused with the periosteum where the bones are subcutaneous. So where you can feel your tibia, at that point, the fascia cruris will blend, will fuse with the periosteum. So two intermuscular, this is one modification of the fascia cruris. Two intermuscular septa, the anterior and posterior intermuscular septa, usually extend inward from the fascial sleeve and get attached to the anterior and posterior borders of fibula. Now, this together with the interosseous membrane usually divide the leg into three fascial compartments. Each fascial compartment has its own muscles, arteries, and nerves. And these fascial compartments include the anterior, the one we are going to look today. We also have a lateral and a posterior. And also the posterior compartment, the muscles are usually divided into three layers by superficial and deep transverse fascial septa. So when we look at the deep, you will see it is further divided. So let's look at the anterior. Now, before that, let's look at retinacula. This is also another modification of the fascia cruris. Around the ankle, the deep fascia is thickened to form strong fibrous bands called retinacula. Now, they are named so because they retain, now this is the function of the retinacula, to retain the tendons around the ankle in place and prevent their bowstringing during the movements of the foot. So they usually hold the tendons in place to prevent them from bowstringing during movements of the foot. So there are various retinacula, which include the superior and inferior extensor retinacula on the front of the ankle. We also have a superior and inferior peroneal retinacula, which are found on the lateral side of the ankle. We also have the flexor retinaculum, which is found on the posteromedial aspect of the ankle. So today we will look at the superior and inferior extensor retinacula on the front of the ankle. So let's see this. You can see this is the skin, the superficial fascia. Then you can see this deep fascia here. You can see it is sending in the septa. This is the anterior intermuscular septum attached to the anterior border of fibula, and the posterior intermuscular septa attached to the posterior border of fibula. So, and this interosseous membrane. Now, those three will divide this into three compartments. This is the anterior compartment here. This is the lateral, and this is the posterior. And you can see you also have the transverse intermuscular septa, which is dividing the posterior into deep posterior and a superficial posterior. But today we are going to look at this, the anterior, the extensor compartment, and not tibia is medial. So the most medial muscle is tibialis anterior, then extensor hallucis longus, then extensor digitorum longus. We also have another muscle known as the fibularis stachys or the peroneus stachys muscle. And you can see it's a neurovascular bundle here. The anterior tibial artery and veins and the deep peroneal nerve. The deep peroneal nerve has another name. Some texts will also refer it as the anterior tibial nerve, and others will also refer it to the nervous hesitance. You will see why. So let's continue. Here we are. You can see the muscles. This is the anterior border of tibia. Then this must be tibialis anterior, extensor hallucis longus, then extensor digitorum longus. Then you can see here are the retinacula. They prevent the bowstringing of these tendons during the movements of the foot. So this muscle, the extensor, usually dorsiflex the foot. We will look at that. So you can see this is the superior extensor retinaculum and the inferior extensor retinaculum, which you can see it is Y-shaped. It has a stem and an upper and a lower band. You will look at that. So let's look at the muscles of the anterior compartment. All of them are usually innervated by the deep peroneal nerve, which some texts will refer it as the anterior tibial nerve, but I prefer using the deep peroneal nerve or the deep fibular nerve. So tibialis anterior, it originates from the upper 2/3 of the lateral surface of tibia, the adjacent part of interosseous membrane, and from its own covering deep fascia, and from the distal part of the lateral condyle to insert into the medial surface of the medial cuneiform. Cuneiform is a bone of the foot, and the adjoining medial surface of the base of the first metatarsal. These are bones of the foot. Action: dorsiflexion of the ankle, inversion of the foot, and usually maintain the medial longitudinal arch of the foot. Extensor hallucis longus. Extensor hallucis longus usually originate from the maybe first we look at the origin of this. You can see this is where tibialis anterior originates. Yeah, the upper two folds of the lateral surface of tibia, and from the interosseous membrane, and also here distal part of the lateral condyle of tibia. It will insert here. So this is the cuneiform, the medial surface of the cuneiform, and the base of the first metatarsal. Here, insertion. Let's look at the tibial extensor hallucis longus. Now, it usually originates from the middle 2 folds of the posterior part of the medial surface of the shaft of fibula and the adjacent part of interosseous membrane to insert into the base of the distal phalanx of the big toe. It usually extends the phalanges of the big toe and also dorsiflex the foot. Dorsiflexion is that movement you do when you are like you walk using your heels. So you walk, your toes are off the ground. Only your heel is touching the ground. So that movement is dorsiflexion. Then we have the extensor digitorum longus, which will originate from the whole of the upper quarter of the medial part of the middle 2 folds of the anterior surface of fibula and insert into the middle and distal phalanges of the lateral 4 toes by 4 tendons. It usually dorsiflex the foot. It will extend the metatarsopharyngeal joint, proximal interpharyngeal and distal interpharyngeal joints of the lateral 4 toes. So those are the actions of extensor digitorum longus. Then we have peroneus stachys, which is also known as fibularis stachys, which originates from the lower quarter of the anterior surface of fibula and the adjacent part of interosseous membrane to insert into the dorsal surface of the base of the fifth metatarsal, and it usually dorsiflex the foot and a version of the foot. So Peroneus fascius is eversion, but tibialis anterior is inversion. So let's look at those where the originator of them. So here we have, here you can see this is your origin of your, this must be your extensor digitorum longus. Then here is your extensor hallucis longus. Then here we have your peroneus fascius and your fibrillaris fascius, and fibrillaris fascius will insert here on the dorsal surface of the fifth metatarsal. And you can see this is where the extensor, the four tendons of extensor digitorum longus will insert into. Then also the extensor hallucis longus will insert here, the distal phalanx of the big toe. So here are the muscles there. You can see its tendon will go to insert in the middle surface of the cuneiform and the first metatarsal. And this is the extensor hallucis. It will come to insert here. And you can see this extensor digitorum. These are its tendons, four tendons, should insert here. Then here the fibrillaris, fibrillaris fascius, the peroneus fascius, should be this small muscle here. Yeah, its tendon is shown. This is its tendon to insert into the dorsal surface of the fifth metatarsal. So now we do that using cadaveric images. Here is your tibialis anterior. Okay. Then this is your extensor digitorum longus and its tendons here. Then now this is now these are muscles of the lateral compartment. This is your superior extensor retinacula and your inferior. Okay. Again, here you can see a tibialis anterior. Then here, deep to it and the line lateral to it, this must be your extensor hallucis longus muscle. Then this is your extensor digitorum longus. Okay, this is your superior extensor retinaculum and your inferior extensor retinaculum. Then by the way, you must know how these things are arranged here. Then on this image, it is this, but we have cut and removed the tibialis anterior to show you clearly the extensor hallucis longus here, and the line lateral to it, this must be a extensor digitorum longus muscle. So anterior tibial artery, this is the artery of the extensor compartment of the leg. It is the main artery to the anterior compartment of the leg or the extensor compartment. It corresponds to the posterior interosseous artery of the forearm. You will look at that when you look at the forearm. Then the blood supply to the anterior compartment of the leg is reinforced by the perforating branch of peroneal artery. Therefore, the size of the peroneal artery is inversely proportional to that of the anterior tibial artery. What does that statement mean? If the anterior tibial artery is large, then there is no need to reinforce it using the peroneal artery, so it will be small. But if the anterior tibial artery is small, the peroneal artery will be large to reinforce blood supply to the anterior compartment of the leg. Then the anterior tibial artery is accompanied by two vena committantes, which are known as the anterior tibial vein. Then the anterior tibial artery is a smaller terminal branch of the popliteal artery given at the lower border of popliteus muscle. It usually begins in the back of the leg at the lower border of popliteus. Then it enters the anterior compartment of the leg by passing forward between the two heads of tibialis posterior, then through an opening in the upper part of the interosseous membrane. Then in the anterior compartment, it usually runs vertically downward to a point midway between the medial and lateral malleoli. So where it enters the foot, it changes its name to dorsalis pedis artery. So dorsalis pedis artery is a continuation of the anterior tibial artery in the foot, which ends near the web between the big and the second toes. Then here are some important relations. In the upper 1/3 of the leg, it usually lies between tibialis anterior and extensor digitorum longus. Then in the middle 1/3, it will lie between tibialis anterior and extensor hallucis longus. Then in the lower 1/3 of the leg, it will lie between extensor hallucis longus and extensor digitorum longus. So why is this happening? Because the extensor hallucis longus it crosses the artery from lateral to medial as it goes to insert into the distal phalanx of the big toe. So that is why you should know these relations. So maybe a diagram to show you that. Here you can see after it has passed between the two heads of tibialis posterior, it will pass through a gap in the interosseous membrane, then run downward. At first, it will lie between tibialis anterior and extensor digitorum longus, then between tibialis anterior and extensor hallucis longus. Then in the lower 1/3 here, this tendon which we have cut should cross it medially so that it will lie between now extensor hallucis longus and extensor digitorum longus. Then you can see here in the foot, it will change its name to the dorsalis pedis artery. Okay. So here we are. You can see the artery here. Okay, maybe just this is a diagram for you to see. Then you can see the muscles here. This muscle is the extensor digitorum longus. This must be a tibialis anterior muscle here. Then here you can see this must be your extensor hallucis longus. And I think here have they shown the peroneus fascias? I don't think so. That should be somewhere here. It's a small muscle. Now, let's look at the relation of structure between the flexor retinacula. This is the superior extensor retinacula. This is the inferior, which has a stem here and the band, upper band, lower band. This is medial side. This is lateral. So attachments of the superior extensor retinaculum is the anterior border of tibia medially and the anterior border of fibula laterally. And here you can see, so from medial to lateral, the structures are arranged. First, we have the tibialis anterior tendon, then the anterior tibial artery, then your deep peroneal nerve, okay, then extensor hallucis longus, then your extensor digitorum longus, then your peroneus fascias should be here. Then in the inferior extensor retinaculum, you can see this tendon is crossing the artery and the nerve medially. So it will be tibialis anterior, then extensor digitorum, extensor hallucis longus, then your artery, then your deep peroneal nerve, then extensor digitorum longus, then your peroneus fascias. So this is the point to note that the extensor hallucis longus tendon will cross the neurovascular bundle from lateral to medial. So that is an important point to note. Then let's continue. Maybe the same. You can see here this first it is lying lateral, then it will cross them to go to the medial side. Okay, then the same here, you can see this is a cadaveric image. You can see this is your tibialis anterior. Then this must be your this is your extensor hallucis longus. And you can see here is your dorsalis pedis, which is a continuation of the anterior tibial artery. Then here you can see your deep peroneal nerve. Then these are the tendons of extensor digitorum. Then this is the tendon of peroneal stachys muscle. Okay, now this is your extensor retinaculum. This should be the inferior because you can see it has a lower band and an upper band and a stem, the inferior one. Then let's look at clinical correlation. We have something which is known as the anterior tibial compartment syndrome, or shin splints, or the Fascia's syndrome. It usually occurs due to overexertion of the muscles of the anterior compartment, especially when the untrained person who lead a sedentary life are asked to walk or run for long distances. Now, the shin splints, or the anterior tibial compartment syndrome, or the Fascia's syndrome, also occurs in trained runners who do not warm up. Muscles of the compartment swell within a tight compartment due to sudden overuse, which may impede venous return, leading to accumulation of more fluid inside the compartment with unyielding walls. So remember the septa and the deep fascia. Those septa cannot yield. They are tight. So those compartments are usually the pressure should be constant, but if you have increased pressure, this will tend to compress the anterior tibial artery and reducing the blood supply to the muscles, which will lead to ischemia and pain. It is frequently seen in freshers, e.g. newly admitted medical students. Maybe they are asked to run, and previously they weren't asked to do so. They were leading a sedentary life, or in newly recruited army personnel who are made to run excessively. Hence, this condition is referred to as army freshers syndrome. So I hope you have understood that. That is this syndrome is synonymous to the next one, which is more serious, which is known as the compartment syndrome. Now, on account of the attachment of the deep fascia to the subcutaneous surfaces of the leg bones and the presence of intermuscular septa, any condition that increases the volume of the contents of these tight compartments, e.g. what might cause increase in volume and the pressure in those compartments, muscle swelling, or you have bleeding. Okay, say you have bleeding of the anterior tibial artery, and they will lead to increased volume. This will cause vascular compression and ischemic damage to the nerves and muscle. When a compartment syndrome is anticipated, it should be prevented. How do you prevent it? By extensive incision of the deep fascia. You cut that deep fascia to relieve that pressure. Okay, that covers the compartment. This is now the incision of the deep fascia is the fasciotomy. Now, compartment syndrome is characterized by the following signs. The 5 P's. Pain. Pain is the most important. Pain, 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 pain. Then we have para. The patient will present with pale skin in the leg. Then we have paresthesia, numbness. Then you have pulselessness. Due to compression of the artery, so no pulse will be detected. Then the last sign to present will be paralysis due to ischemic death of the muscles. So remember these signs: 5 P's: pain, paresthesia, pulselessness, paralysis. And thank you for your attention, and subscribe for more anatomy and biochemistry content.